Well, thank you. What a real honor. And thank you to Sam and to Kevin for inviting me. Thank you all for the work you do, because I know when you go at home you feel alone in this and the only voice of reason. And I feel like these gatherings are kind of like a therapy session for us because we're all in together. We're on the right the path. We wear the white hat in this issue. So, as I was told, I'm an emergency physician, and at the very beginning of my career, I was told I'm not doing enough for pain, that I shouldn't judge someone else's pain, I need to prescribe more, and nobody gets addicted. And I was taught wrong, and my medical profession was taught wrong, and I'm now in the process of correcting the mess that we created. And when it comes to marijuana, I say, fool me once, shame on you, fool me twice, shame on me. And I'm not going to let that happen again, as I did at the beginning of my career. And now when I see young residents and young doctors coming in and they give me a presentation of their case and they say, oh, this patient has, this chest pain or abdominal pain or whatever it is, and, they tell me about their medical marijuana use, I want to slap their hand and tell them, don't use the word medical marijuana. What is the medical case? What's the diagnosis? What's the indication? What's the doses? There's nothing medical about it, but even that sense has gone into the medical community and is a problem. So what I wanted to show you today is just some of the cases. I work at a busy emergency department downtown San Diego, and my day-to-day life of what I see. First of all, this is kind of what we're seeing in the community, not in the emergency department. My husband is a dentist. One of his patients is a concealed carry person in law enforcement, and he asked him, okay, well, what are you protecting these days? Is it, banks, schools? And their number one business is protecting the marijuana industry in California, and they're going in cars, not armored cars, regular cars, at least 2 armed guards at the same time, and huge amounts of cash. And that's really what's driving everything, as we've said. The daily thing that I see, I'm going to kind of share some cases with you, is what I call an audible diagnosis. Audible means I could be sitting at my computer with my back to the patient and I could already make the diagnosis because I could hear it. It's the loudest retching sound that you could ever hear. It's not normal, and I'll say, that person is scromiting. Talking to the patient, if you can, get through all the loud sounds and, and the emesis spacing that we give them, not full, by the way. They're just retching very loud, and it's so horrible that they're in pain, and they just really want something for pain. And the patient may be, 20, 30-year-old, thin person, and, this is not the first time this has happened to them. They've been to lots of doctors. They have this terrible abdominal pain. Nothing works for them. They've had CAT scans and endoscopies, and nobody can figure out what's wrong with them. I'll say, well, do you use marijuana? And they'll say, well, I have to. I need it for my appetite. And I said, well, that's what's causing your problem. And I'll say, well, and they won't believe me. I'll say, you have cannabinoid receptors in the brain. We've seen they also have cannabinoid receptors in your intestines, and it's making you throw up, and it's hard for them to believe. And what do they want? They're in pain. What are they asking me for? They're asking me for pain meds, Dilaudid, and we are giving it to them. And we're starting to see, and that's really how I got involved in marijuana advocacy. I was seeing that we are creating, from marijuana addicts, we're creating opioid addicts. And we're giving them marijuana, giving them Dilaudid for their marijuana addiction. And that's when we created our guideline. And we are very proud of the guideline. We said we did the same thing with opioids in emergency departments. We created a guideline that, we're going to restrict opioids. We're not going to refill your medications. You're not here in the emergency department to get long-acting opioids. And so we created a whole standardization for opioids and had that in San Diego and around California, and it was very successful. I said, we need to do the same thing now with cannabis hyperemesis syndrome, and created this guideline, had a press conference, and one person showed up. There was a second person, but they were a pothead, and they weren't interested in what we had to say. But this one lady, and I think we should give her some award, because she really changed my life as a physician, because she listened attentively, and since she was the only one in the audience, it gave me the courage to go off script and say, you know, the hallmark of cannabis hyperemesis syndrome is scromiting. And she said, what's scromiting? And I said, it's screaming and vomiting. And she put that in her article, and it went viral. And it's the best thing that ever happened to me in my career, even as a physician, because I would tell patients, for 5 years, I'd tell them, you have cannabis hyperemesis syndrome, you need to stop using pot, and they'd say, you don't know what you're talking about. But now I'll say, hey, you're scromiting. You look it up, and it'll be in their own information that it's a real syndrome, and they'll feel, oh yeah, I have scromiting, and they believe it, and now they'll kind of listen to me. So I'm proud of that one. And it's a completely made up word. But I think we should change the diagnosis. This second most common thing I see, I told you the Audible Diagnosis, this is the visual diagnosis. The visual diagnosis is a guy with a spit bag over his head. My friends in law enforcement, they bring them in. They're like, you know, 6 strong dudes there, and I'm like 5'1". I stand away from all the big action there, but don't judge me by my size. I come in with the chemical sedation and get control of the situation with, this patient's on drugs, and I always laugh, how am I going to get control of the situation? With more drugs. Yeah. So we pump them up with Ativan, Haldol, ketamine, and we have to for the patient's safety, for the staff safety, until they come down. And then we figure out, okay, well, what's going on? And we can guess, in San Diego I'd guess methamphetamines, but you don't always know what's going in there. While they're down, that's my trick to get my urine sample, otherwise it's hard to get, and find out what's going on. And a lot of times, it's just marijuana, acting crazy. Agitated delirium, very common. We see that in law enforcement, we see that in the medical community multiple times a day, unfortunately. And again, when people say nobody dies from marijuana, we have case after case, and we're just not calling it a marijuana death. And I will show you more information about that later. But there have been several cases of people acting in psychosis that ends up in death or serious harm, and it's a regular case. And we have a huge problem across our nation now with mental illness, and there is an association with drug use, all types of drug use. And in our emergency department, the problem is psychiatric boarding. Boarding means you're staying and it's taking you a really long time to get to a mental health facility. People wait not just hours, they wait days, and children can wait a week living in an emergency department waiting for admission. And I ask, what percentage of them are on marijuana or drugs? And are we even asking that question? We measure it, but we're not saying that. And I say that we have a huge amount of influx in psychiatric illness and boarding in our country, and to not look at the association with drugs and marijuana is a big mistake. So here's another, San Diego is a beautiful place to visit. I encourage all of you to come. And it's a great place for conventions. And here's a gentleman who came in for a convention then came in, and he came to the emergency department saying, something is wrong with me, doc. I can't talk right, and my arm's not right, and something is wrong with me. And I think, take more care of these patients, because before I send them on a plane back to Atlanta, I need to make sure he didn't have a stroke. He can't talk, he can't move his one hand, something's wrong with that. So did a CAT scan, did an angiogram of his brain, did the whole lab work, and several hours and several $1,000s later, everything's normal. So I come back to tell him the good news, make him copies of everything so he could take it back home, and then he takes out of his pocket this little package, and on it says hangover remedy. and inside were gummy bears. And he said, I went out with my friends last night from San Diego, and they gave me this. This morning I had some munchies in my hotel room. I took one of these things, thought it was, hangover remedy, and it was marijuana gummy bears. And that's what caused your stroke-like symptoms. That was a very expensive way to figure out you had a marijuana poisoning. And that's why something else that's happened. Another lady, this lady came in after passing out. She passed out and had a horrible, way worse than the picture here, laceration to her scalp. I had to debride it, I had to put sutures and staples. It was quite a messy job. And that's just the head. I had to figure out why she fainted. I mean, people who faint, if there's a medical reason for fainting, I'd admit them to the hospital, check out their heart. She may have had an arrhythmia. But she was there with her husband and teenage children, well-to-do family, which is kind of unusual for our emergency department. But she was there, and she kind of knew what happened. She had fibromyalgia, and for the past 2 years, she's been buying gummy bears for a dispensary, and nothing ever happened. It helps her fibromyalgia. But this time, she took a gummy bear, and she fainted. And she said, well, but I've taken it for years. I said, well, was it a new batch? It was a new batch. Well, how do you know what you were getting for the past 2 years compared to what you just got in this package today? And the disappointing thing was her reaction, and the family's reaction was like, oh, well, that's why we need better laws and controls, instead of like, well, maybe I shouldn't use the gummy bears anymore. And if she was using the gummy bears for a headache, she was leaving the emergency department with a much bigger headache than when she started. Anyway, the packaging, there have been studies that show that packaging labels are not accurate. Surprise, surprise. Code trauma, we're a level 1 trauma center, and on a regular basis we hear overhead, code trauma, code trauma, code trauma. About 14 different professionals come into the trauma bay waiting to see what happens and see various injuries. We measure marijuana when there's a fatality involved, and we try to measure marijuana on regular accidents. It's part of the protocol, but if people don't give us a specimen, then we don't know, and it doesn't enter the medical diagnosis. We don't document that. So we have, I've seen, 2-car head-on collision. The guy admits that he was high on marijuana. Everybody knows it, and it'll never enter the statistics. And yet we see that. And then thank you, Dana Stevens, for your mission about driving high is a DUI, and that's definitely a problem with all drugs. Again, tourism, this one reminds me of Dr. Hurst's last slide when she showed the tolerance effect. So this is a guy who was a tourist to San Diego, and he went out with his friend, and they were out smoking, and he called 911, lights and siren, into the emergency department. I'm dying, I'm dying, I'm dying. And the paramedics did their thing. They check a sugar, they do an EKG, everything looks good. And his friend is there. She is like, she is mellowed out, and she's fine. They're smoking the same thing, and he is sure that he's about to die. And I told him, you know what? You're going to be okay. You're not going to die. This was all the marijuana. And knowing that, telling him that, doing tests didn't help him. I actually gave him a bunch of Ativan, again, more drugs for the drugs. It seems silly, until he calmed down, and several hours later in the emergency department before I was able to send him out. So I don't know if he had a great tourist experience with the marijuana. Another young girl, 14 years old, comes to the emergency department. She's there with her mother and her grandmother and her sisters, and there's something wrong with her. Something is wrong with our sweet child. She's already been to the doctor. They've already gone to the clinic, and the clinic couldn't figure out what's wrong with her. She looks like a healthy girl to me. And I said, is she depressed? Maybe depression is going on too. They thought, yeah, she might be depressed. But you know what? We're in the emergency department. We get blood work. We get things. What can I check? Everything's normal. Are you using marijuana? and that drug screen already shows, yes. Do you think that that's a problem? You know, the grandmother says yes. And here's the opportunity for me to say, you know what, you're growing, your body is growing, you're maybe as tall, almost as tall as you're going to get, but your brain has much more growing till you're about 25 years old. You're stunting the growth of your brain, not just your body. And maybe that message was across. But the good thing is, with this patient, that was the same day my young daughter was shadowing me in the emergency department. She's a little older, but she showed that story with her friends, and they're all talking about your frontal lobe, you know, you know, to protect your frontal lobe from these drugs. So that was good. Here's another one, and you know, Officer Murphy was talking about a San Diego case, and I was thinking, I wonder if that was my patient. But we had a patient also who had, this was a waxing and a heavy concentrate, we don't know that when you come into the emergency department. We just know that your blood pressure is low and you're not breathing. We put you on a ventilator. We put IVs in. We get your blood pressure up. We admit you to the ICU and kind of do all the things to kind of save you, and then ask, you know, what was wrong, try to figure that out. But this was all marijuana. This was a patient who almost died from marijuana with the concentrated, it's 90% THC. He and his friend, and that's what it was. And I always learn these things. It's like, what? Show me the video on YouTube. What was that thing? Again, we heard before, it's affecting our pregnant women, and I'm told by my friends at the Children's Hospital that more and more women are using marijuana to help their morning sickness, which is really sad. But again, as we heard, it causes the placenta, it's in the breast milk, it's a problem. Pediatric exposures are terrible. The seizures, we've talked about that before, that's help with CBD, and you could actually get it legally. If you know someone that has a child with a seizures disorder, we can get them the real CBD to help. You don't have to buy the snake oil that you're buying on the internet. You don't even know what you're getting. M&Ms, one of my favorite candies. I really like M&Ms, but in the emergency department, M&Ms are marijuana and meth, or marijuana and methadone, because people use things together. We like to isolate things, you know, next door is opioids and this one is marijuana, but that's not how things go. People are in a mix. I'm going to skip over the addiction slides because of time, and just kind of because I wanted to share with you the data that I've been working on. But, you know, there are different things that Americans want, and they don't want to go to jail. They want a medicine. Some people want recreational use, but the whole issue with medicine, I think, is really offensive to me and my profession. I can't give you a prescription for amoxicillin without a history, a physical exam, a doses, a prescription, accountability, asking for allergies, and yet marijuana is okay, and this is my medicine. And again, that's a disgrace for my profession. I don't think they should be able to use that word. And when they do studies and tell you that this is so helpful and cures everything in the world, again, how many people were in that study, and what was the dose that is used, and is it even relevant to what we're doing today? And to make an analogy to the opioid crisis, that whole crisis started with one letter to the editor and 38 patients, and yet we unleashed this wonderful drug on everybody. And now we're doing the same with marijuana. Again, I get jealous from other people's statistics. When I was looking at the opioid epidemic, I was very jealous of gonorrhea and chlamydia. And why would I be jealous of an STD? Because they had mapping. The CDC has hot mapping of, I know where there's a gonorrhea and where there's syphilis. And if I'm living in the 92103 zip code, I need to be testing for syphilis more. And I said, I want that for opiates. We have way more deaths for opiates than we do for gonorrhea and chlamydia. And I was able to, nag enough to get that kind of mapping. And I'm able to do that now. And now I want the same thing for marijuana. We have this wonderful opioid dashboard all over every state. Where is it for marijuana? Where is the death certificates? I see it for alcohol, for drugs, for suicide. I got report cards of everything that's happening for suicide, and marijuana just gets a pass. It gets a pass. It's not even on the radar screen. And so, nagging enough, I finally got some data out of San Diego, and here it is. Not a surprise to me, but it makes a nice, like, green up effect here of the number of emergency department visits just in our county from 2006 to 2014. I know it's not even the most current data, up 830%. ED visits. No wonder. It's just validating what I see with the patients that I'm seeing. Poison centers, calls not so much leveled off. And then the other research that I really want to share with you is what I call the death diaries. When I started working on the opioid epidemic, people said, doctors are, killing people with their prescriptions, and physicians said, if you take your medicines just like you're told, you wouldn't die. So I went to the medical examiner's office and created a really nice relationship and really studied down to the pill what people are dying from, and not to the pill, to the doctor, to the pharmacy, to the deepest level, and I called those the diaries, because as an emergency physician, my job is to keep you alive. Anytime somebody dies, it's a failure on our part. And to go to the medical examiner's office was really a defeat. I mean, it's like a failure after failure, and the only story was the prescriptions they were given before they died. And I realized it's not an opioid epidemic, and we call it opioid epidemic, but it's not. It's a prescription drug epidemic if you're looking at the supply chain from the medical side. And very few people die of one drug. 80% of people die of a combination of things, all sorts of things, and not just opioids. Benzos are right up there, and that combination is a killer. And one of the projects that I did is sharing letters to physicians who had a death to let them know, hey, dear doctor, just so you know, your patient had died, maybe go to this website and here's some things that you could learn, and publish that information. And the show, The Doctors, thought that was attractive and invited me to be on their show, so I got my 4 minutes of Hollywood, and that was kind of fun. But I realized I need the same thing for marijuana, because when a medical examiner gives his report and I looked at it, I would see the number of opioid deaths and Benadryl and acetaminophen and all over-the-counter medications, and they listed every single drug that somebody died of, and it's like, well, where's the marijuana? And they said, well, no one dies of marijuana. I said, well, how do you know? How do you know no one dies of marijuana if you don't check it? And so for 7 years, I've been asking, where's the marijuana data? Where's the marijuana data? Where's the marijuana data? And finally, with the new medical examiner's office, I got the data. He said it was like pulling teeth and some hair, and this is what he showed me. And again, you could see here the number of marijuana THC found in deaths in San Diego County has gone up from 281 to 462, over 60% of deaths. And you'll say, well, more people are smoking. Look at the number of total drug deaths that have gone up together. And now tell me there's not an association with marijuana and all sorts of other drugs. And have you met a heroin addict who hasn't started using marijuana first, and yet marijuana is okay, all the other drugs are bad? Anyway, so I thought that was fairly alarming, and now I've called this the marijuana death diaries. And looking at demographics, this is a male disease. Mostly ethnicity is unknown, but if we knew the ethnicity, it was white. And then look at these cases. 1-year-old, death is undetermined. Medical examiner says undetermined when there's still a criminal investigation. A baby dying with marijuana in the system, is that ever normal or natural or okay? A 15-year-old, a 19-year-old struck a tree, 21-year-old jumped off a bridge as a suicide, 76 suicides with marijuana, 31 drivers with marijuana, fall while hiking, really, is that really an accident? Motorcycle accident, 9 motorcycle accidents, 23-year-old with pneumonia, really a young person dying of pneumonia. People do, I mean, that's unusual. And tell me that something that you're inhaling doesn't make your pneumonia worse. Pedestrians, walking and not paying attention, heart disease, a huge correlation of heart disease. And then I researched this further. The World Health Organization has documented an association of hypertension and cardiac disease with marijuana. How come we don't have that on our radar screen. Anyway, the list goes on, and I gathered this up in statistics. Out of every single investigation by our medical examiner's office, 15% were associated with marijuana. A lot of them were drug overdoses, natural deaths. What's natural? I'll show you. Accidents. Is it really an accident? Suicides and homicides. If we look at just looking at the drugs, they're divided upon illicit drugs or prescriptions or alcohol. And there is a huge association with marijuana. And each of these, 30% association with each one of these around marijuana use with each one of these type of drugs. Now, the FDA has a black box warning about opioids and benzodiazepines, because we know that CNN depressants are additive. And so we've seen about a 20 to 30% deaths with both those opioids and benzodiazepine together. We realize it's dangerous. They have a black box warning. To me as a physician, that means don't ever prescribe the two together. You can't be careful. That be careful means watch you until your respiratory rate goes down. I don't know what that happens. But where's the black box warning for marijuana and opiates? Where's the black box warning for marijuana and benzodiazepine? Where's the black box warning for any of this? We don't ask the questions that we even need to be asking or document that. Natural deaths was also really fascinating because of the number of cardiac deaths. Again, if I see a 33-year-old with a sudden death, that doesn't mean that it was just an accident. I mean, there is an association here that we're not even measuring or even acknowledging. I have to tell you that when I got the data, the whole Excel file for marijuana cases was in a different case, and then regular drugs were in a different type of Excel file, and I had to have my son help me merge the two to even get this. It's so far off the radar screen of anybody measuring it, and it's so important while we're unleashing this poison on our country. Accidents, again, lots of drivers, falls, pedestrians, motorcycles, electrocution, all these things are considered accidents while you're high on marijuana. Suicide risk, 17% of, almost 18% of all suicides were considered or had marijuana, and we have a huge upswing in suicides in our country. Are we looking at the causes of that? Why are all these people? It's horrid. Homicides, almost 30% association of homicides. And I told you about the black box warning. I hope we really learn our lesson here from big tobacco. It took us 50 years and 7,000 publications before the Surgeon General put down his warning, and another 20 before we finally banned it off flights. And I really hope and pray that it doesn't take us that long to figure this out. And thank you all for decreasing the time that we get this right. And here's the data we need to see. We really need to duplicate what they're doing next door with opioids, what we're doing with marijuana, and find out about fatalities and motor vehicle accidents and looking about cardiovascular deaths. I really want the CDC they do such a great job and so smart on what they're doing. When they say something, we listen, and they need to do a lot more for us here on this issue. So thanks.